Lots of people joining us today. This is fantastic to see. Welcome, welcome. I'm not sure if everyone has their chat box available today, but we will be utilizing that. So be sure to try to get that open so we can have some chat throughout the presentation. And we will be mindful of everyone's time. I know that we are at 1:04 already, so I would just like to go over a couple of housekeeping tips before we get started. Like I had mentioned, we will be utilizing the chat box today. If you guys could go ahead and open that up and add in there where you are joining us from, that would be greatly appreciated, as well as if you can tell us what your discipline is. We have people still joining us, so we'll give them another minute. Oh, welcome from Yukon. Thanks for joining us, Aaron. No, Montreal, Martine. Fantastic. Alberta, we have from right across the country today. This is fabulous to see. Very nice, wow. So before we get into things here, thank you all so much for joining us today. This is the 5th session of our evidence-based palliative symptom assessment and management. Today we'll be discussing anxiety. So we're very excited to have you join us. If everyone can just let us know in the chat box if you can hear me, that would be great. We'd just like to make sure that we're not having any technical issues today. Thank you for confirming. That's great. Fabulous. And to begin, we would like to do a land acknowledgement. So we would like to acknowledge that the land which we are gathered on today is the traditional territory of the Anishinaabe Nation, specifically Chippewa Tribe Council, comprised of Chippewas of Beausoleil, Rama, and Georgina Island First Nations, and more recently, the Mississaugas of the Credit River First Nations. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant and agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited into this covenant in the spirit of respect, peace, and friendship. Most of us have come here as settlers, immigrants, or newcomers in this generation and generations past. We are all treaty people. Every day, we are mindful of broken covenants, and we strive to make this right. We commit to collaborating based on the foundational assumptions that Indigenous people have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. Okay, so I'm just going to hit admit for a few more people here. Perfect. Today we are discussing anxiety, and we are here as part of the Palliative Care ECHO project. This is a 5-year national initiative, and we are in our 2nd year of our program. Perfect. Okay, and we would like to thank Palliative Care ECHO project as they are being supportive of us in our efforts, as well as Health Canada for financially supporting the project as a whole. Thank you so much. It's time for introductions. My name's Amanda Tavalda, and I am Communications, Fundraising, and Community Relations Specialist with Hospice Aurelia. Today, our presenters are Nancy Good-Kennedy and Sherry Hubbard, both with the North Simcoe Muskoka Hospice Palliative Care Network. Ladies, the floor is all yours.
Thank you so much, Amanda, for that excellent introduction. So as we start to think about our learning objectives, I want you just to bear with us for a minute because Nancy is currently sending you an exam that will need to be completed at the end of this presentation. How did you feel just then? Were you able to concentrate on what we were saying? Did you feel any anxiety when I told you there was going to be an exam? Did your heart rate get up a little bit? Were you maybe sweaty? Did it stimulate any negative thoughts surrounding, I'm not prepared for an exam today, I didn't know there would be one? And did you feel like leaving? So thinking about those natural responses to anxiety and stimulus within our day-to-day travels, that we might feel anxiety. It is a natural, normal process of being human. But there are times in our lives where it is coming to a point where we might need some intervention. And so our learning objectives today, by the end of the session, there is no test, by the way. I just want to make sure you know that. Find the symptoms of anxiety, utilizing the Cancer Care Ontario algorithm and the ESAS tools to determine the level of anxiety for your patients, and then determining the course of action based on the level of anxiety and what is best for that patient and family in that moment. So Nancy, I'm going to hand things over to you about identifying anxiety. Thank you, Nancy.
Thank you, Sherry. So what is anxiety? With a better understanding of the condition, we will be better equipped to identify anxiety and also to implement treatment. But part of this understanding is rooted in anatomy of the brain regions itself and the sympathetic nervous system, where norepinephrine, serotonin, dopamine, and GABA are either locally released or carried in blood or tissue fluids. And they may participate in either initiating, sometimes perpetuating, and certainly aggravating a pathological process. So in addition to the activity in the brain region, it's also important for us to consider the neurotransmitters providing communication between these regions. Ernest Martin noted in the neurobiology of anxiety disorders that those suffering with anxiety could be caused by a reduction in GABA, or sometimes also an increasing glutamine or glutamate. A look inside the brain, we know that the brain is divided. We know that the brain is divided into the cerebrum, the brain stem, and the cerebellum. The cerebellum will be a bigger focus for us here as we unfold the work that lies within the amygdala. It processes emotional stimuli, it initiates the appropriate behavioral responses, and helps with an expression of fear, aggression, defensive behavior, and sometimes plays a role in the formation and retrieval of emotional and fear-related memories. For all our visual learners, one of which I am, this diagram on the left, you can see a division into lobes. So you clearly have the frontal lobe, the parietal lobe, and the temporal lobes. The diagram on the right is a slice through the midline, where the amygdala lives in this medial temporal lobe. It's just anterior of the hippocampus, and it's a paired structure. There's also one located in each hemisphere of the brain. So figure 2 depicts the amygdala, and it's involved in a fear circuitry. So the fear response actually starts in that almond-shaped set of nuclei. It's in the temporal lobe, as earlier mentioned, and it's heavily interconnected with cortical regions, including the limbex cortex. It's dedicated to detecting the emotional salience of the stimuli. A good example of this would be the sight of a predator. That triggers a fear response in the amygdala, and it activates areas that are involved for those motor functions, like you see here. Now that we have a good understanding of what's happening pathophysiologically, let's turn to Sherry. And Sherry will discuss with us how anxiety can manifest in our patients. I think you might be muted, Sherry.
There we go. Thank you, Nancy. Sorry about that, guys. I think, when we talk about the nervous system and how it works, it's always great for us to have that really good overview to remind ourselves that there is physiological things that are happening. And when we're assessing patients for anxiety-like symptoms, we must be very careful that we do a really fulsome head-to-toe assessment and review of all of their medical history, and looking particularly at medications and other causes that may give us symptoms that are very similar to anxiety. Sorry, using the DSM-5, and I did have to look that up to remind myself what it meant, what the acronym meant, the Diagnostic Statistical Manual of Mental Health Disorders, 5th edition, describes anxiety as a normal human response to stress, and it can be beneficial. Although as these anxieties can evolve, we might have excessive fight or flight reaction and increase that sympathetic nervous system. So we really do need to make sure that we understand that anxiety may be present as part of one of several psychiatric disorders. Anxiety is often a prominent component of acute or chronic pain syndromes, dyspnea, nausea, or cardiac arrhythmias. So we need to make sure that we rule out all of those physiological things that may occur and the underlying side effects of those disease processes. We need to look at drugs. So making sure that we're looking at all of the medications the patient has been on or is currently on, and looking to see if those drugs might be stimulating some of these symptoms. So corticosteroids, and we see a large component of patients with chronic disease and cancer on pretty high doses of corticosteroid, which can create those symptoms that are similar to anxiety. Psychostimulants that people might be taking, and some of the antidepressants. As we know, there is lots of substance use in our population, and we need to make sure that someone is not suffering from drug withdrawal, whether that be alcohol, opioid, benzodiazepine, nicotine, clonidine, antidepressants, and again, our friends, the corticosteroid. Looking at that process, looking how long it's been since they withdrew from that medication, and is there intervention that's required? Maybe they stop something very suddenly and need to look at that process going on. Are there metabolic causes that we haven't identified, such as hyperthyroidism, or syndromes of adrenergic or serotonergic excess? And is there existential or psychological concerns surrounding chronic disease, loss of ability, legacy, family, finances? Is it religion or spirituality? Looking at our domains of what make a person and making sure that we actually support those types of issues. Concerns around dying. Not everybody thinks about dying as a normal process, as we know, right? When we look at anxiety in chronic illness, it is a normal reaction. And I want you to think about any time you've been to the doctor and anticipating bad news, how you felt when you were there. And it is very common that in advanced chronic illness and when people are nearing the end of their lives, that they may feel anxious. And while some degree of worry and sadness is very normal, and it's a normal human reaction, the degree of anxiety and depression may be or become pathological, and it may require establishment of a specific diagnosis and treatment plan. And anticipating that patients will have emotional reactions should not stop us from, as practitioners, to pass over that possibility of diagnosis and amendable therapies. And we still, when we think about mental health, we still have a society that is very judgmental and unaccepting. And depending on where you are in your growth and development and how you think about mental illness and the ability to control it and treat it, we need to be very mindful that people may hide those feelings for fear of being judged, right? So when we talk about over time, the issues of chronic stress increases that cortisol production, can cause abdominal obesity, GI irregularities such as diarrhea, headaches, chronic pain, dyspnea. And all of those fears of anxiety, of these symptoms increasing and getting out of control, fear of letting their family down or their loved ones down because they're incapable of doing the things that they once did, and fear of being judged. All of those play a participatory part of this illness. And people, regardless of their age, do really not know the circumstances of their death. So fear certainly will generate a remarkable set of emotions, including fear and anxiety. Especially as we get to the end of our lives, we start to have a greater awareness of our mortality and the unknown of the dying process. And especially if you have witnessed a bad death in the past, will certainly abate those feelings of anxiety surrounding death and dying. Death and health are closely related, and so working on death education does help improve the quality of life, particularly in our elderly population. By normalizing health education and ways of coping, we can help reverse or help stabilize anxiety. So facing death naturally as just another part of life will help our healthy aging become possible through education and proposals related to the integral health of our elderly people. There are many validated tools that we can use to assess patients' anxiety. And one of the tools that we're going to talk about is the ESAS. And it's a validated tool that is strongly recommended that we use. It is universally recognized, and it helps us understand what the goals of care are for that person, what interventions are appropriate for that person, and particularly identifying red flags and what we should watch for keeping that patient safe. So I think when we're talking with people, it's always challenging, and it causes anxiety for healthcare providers as well. Anytime we're sort of digging deeper into these anxiety or depression. But there's some important things that we need to remember, that it's important that people have whatever information they need. So finding out how much information is for them and finding out whether they want to know anything. Because some people need an in-depth analysis of what's going to happen to them or what the physician thinks is going to happen. And some people don't want to know anything, and they're happy for their family to know about that. But I think that being aware and having information will help with people's sense of control. It will also increase their safety if we're monitoring them and making sure that they're not at risk to harm themselves. We can make sure that symptom management is well managed, all of the symptoms, including anxiety. Talking about anxiety or not talking about it, depending on what is for the patient. And respecting the coping mechanisms and strategies that people have already developed into their own lives. And we really need to find out what has happened in the past, what is their experience with death and dying, what are they most afraid of, and what are some triggers? Have they experienced trauma in their lives, and did they receive treatment for the same? And we need to use validated scoring systems that everyone has an understanding of what that means. And we need to make sure that we understand and validate the patient's way of coping, because we haven't lived their lives with that, and we need to have without judgment as we go forward. So Nancy, I'm going to turn it over to you for the tools, and hopefully we'll all come away using these algorithms and these tools to help our patients.
Thank you, Sherry. So this guideline, released by Cancer Care Ontario, is intended to help healthcare professionals assess and appropriately manage a patient's cancer-related anxiety. However, I really just wanted to draw your attention to the fact that this is a wonderful screening tool, and it's not just reserved for cancer patients. We use it as well for people with COPD. I think we've all had the experience with our COPD patients that they can sometimes be a little bit like a hamster on a wheel, where they become anxious, then followed by the shortness of breath, then they become shortness of breath, followed by the anxiety. So if we look at the Cancer Care Ontario algorithm, it really does help us determine mild, moderate, and severe. And if you just follow down through the framework of lines and colors, it actually also helps us determine how we're going to treat our patients. So as we carry on, and we use ESAS as one validated assessment tool, and we're particularly focusing on the ESAS today, mostly because our Cancer Care Ontario algorithm mentions ESAS as a useful tool. So we use it at critical times in the disease and or during a treatment process. We use it when our patient changes, any point of transition at all. We also use it during stressful life events, and we review those symptom reports with the patient and with the caregiver, and addressing any other distressing symptoms with the patient that are identified. So with the ESAS tool, it's actually meant to be performed by the patient themselves. And if they rate a symptom at 0, it means it's not present at all, and 10 is the most highest level that they could give it. So other examples of common anxiety measurement scales are the GAD, which is the Generalized Anxiety Disorder Assessment, and the BAI, which is the Beck Anxiety Inventory. These assessments ask questions that are related to how often the anxiety symptoms are experienced and actually how disruptive they are to their lives. Based on the responses, a determination of mild, moderate, or severe anxiety will be provided. So let Sherry go through the screening questions.
When we start asking patients questions like this, I know it's challenging, but I know that you can all do it. So just take a nice deep breath and, center yourself before you start the questions. And remember that you're not going to make somebody worse by asking these questions, where actually our goal is to help them. So I would start my questioning in something like, I'm hoping that we can talk about where things are in your illness. What symptoms are you feeling? Do you feel nervous, anxious, on edge? Do you feel your heart beating fast? Do you feel breathlessness? Do you feel that you may not be able to stop or control your worries at any time? Can you tell me what you think is causing these feelings? Are there triggers? And ask the following questions to clarify and frequency and severity of the anxiety. How long have you been feeling anxious? Has it persisted for longer than 2 weeks? Is this anxiety affecting your daily functioning? And again, that 2-week period of time. Is this anxiety affecting your sleep or mood and persisting for longer than 2 weeks? I like to also use the I wish, I worry, I wonder when I'm talking to patients. It helps us begin these conversations with respect, reflection, and compassion. Anxiety is normal, and giving the opportunity for patients and families to express their anxiety and their upset about their diagnosis, and allowing some silence. And I know that's really hard for a lot of us. It's uncomfortable. But that silence gives time for people to digest what's been talked about, think about what might come next, and really trying to determine how much information that these people can actually process in one visit. And I know that we're all very time restrained, everybody's very busy, but these conversations take a lot of time. And we need to recognize that sometimes people cannot talk about more than 1 or 2 things in a session. So keeping those things in mind and being really allowing the patient to drive where we go, and just asking the correct questions will be helpful. So Nancy's going to start off with the Ontario Cancer Care Ontario. There we go, I got it. How do we break these down into mild, moderate, and severe?
Let's just start with, let's determine to what extent the anxiety is interfering with your activities of daily living. So as techniques to manage the condition of anxiety unfolded, and we refer back to the Cancer Care Ontario algorithm, it's helpful keeping in mind the levels, mild, moderate, and severe, are a reflection of the intensity of those symptoms that were captured back in the ESAS scoring. And the slides that follow, they'll help us take a bit of a deeper dive into this. So mild, which was scored on the ESAS as being between 1 and 3, would prompt the clinician to certainly respond by discussing and normalizing the feelings of anxiety with their patient. being mindful that people worry about things such as health, money, family problems, but anxiety disorders are really different from our day-to-day concerns. They involve more than just temporary worry, and they can escalate over time. So by us providing education and reviewing the past strategies, perhaps suggesting new strategies that they could add to their existing toolbox, we really are setting them up for success. And is that not our goal, right? And of course, it's a good time to actually, again, review their medical history, just ensuring that they are well managed. Moderate anxiety on the ESAS score is between 4 and 6, and it prompts us to really try and figure out if there are any other contributing factors like stress, maybe due to an illness, perhaps a chronic stress, and sometimes personality does play a role. Having blood relatives with an anxiety disorder, as well as the misuse of drugs or alcohol. Also asking questions and actively listening. And when I say actively listening, I mean really truly listening for the responses from your patient. And the use of anti-anxiety meds, either present or past, as well as having previously been referred to a mental health professional, that should alert you as well. And a severe anxiety is it's not a normal diagnosis. It's not a formal, rather, diagnosis. It certainly is a normal diagnosis, but a level of how serious the symptoms have impacted the anxiety disorder. So that's rated at a 7, between a 7 and 10 on the ESAS, and the symptoms can become a really persistent problem. They can interrupt the daily functioning, impact the quality of life, and really become too difficult to manage. The long-term impacts from severe levels of anxiety symptoms can also result in medical conditions. Sherry did mention some of those, but heart disease, gastrointestinal issues, and also a lowered immune system. Severe anxiety can even bring about suicidal thoughts. And for extreme cases of severe anxiety, it's likely that an anti-anxiety medication will be prescribed by a psychiatrist, of course, along with therapy. So anxietycanada.com offers online support for registered clinical counselors, and they run a program called MindShift. You'll hear me talk a fair bit at this point about the non-pharmacological management of anxiety, because as healthcare providers, we always try to work with non-pharmacological interventions first. So the MindShift, it's a form of cognitive behavior therapy, and it runs in small groups over 8 sessions, and it's run probably about an hour and a half, is my understanding. They have a great website, and you can register on the website. I think their next session actually begins on November 2nd. So complementary medicine and herbal medicine have developed globally, and these new treatments have gained a special status and a value. Complementary medicine treatment is accepted as part of nursing care in the United Kingdom, and nurses in over 30 countries are actually licensed to use complementary medicine therapies, such as aromatherapy in nursing care. Aromatherapy is a type of complementary medicine in which the volatile oil of plants is used to promote the level of physical, spiritual, and psychological healing. Inhalation and massage tend to be the most commonly used forms. And the damask rose, I always like to speak to that. The damask rose is actually used to strengthen the nerves, and it's also used to treat anxiety and depression. And as we learn more about the brain, there's a lot of research now benefiting meditation. So slowing your heart, learning to stimulate your vagus nerve. The vagus nerve being the cranial nerve, which runs from the brainstem into the abdomen. It has effects on both glands and visceral organs. And it does help slow that respiratory rate and indirectly the endocrine secretion. So you just know really that there is science behind breathing deeply, as it does signal relaxation. And being mindful can help you be more present. And actually, when we're more present, we're less likely to worry about what happened yesterday or what may happen tomorrow. Therapeutic touch is also another complementary therapy that is widely accepted and used, and was developed in the 70s by a nursing professor. Therapeutic touch is associated with the science of human beings theory, where human beings live as an energy system. And it suggests that there's a continual interaction within the energy fields and within the environment. So good health is actually a result of when those two fields meet. It's a typical session of therapeutic touch would run about 20 to 25 minutes, and it's a hands-off technique. Formal music therapy was defined also and was first used by the United States War Department in 1945. It's the clinical use of music and used to accomplish individualized goals, such as reducing stress. Music therapy experiences include listening, singing, playing instruments, or composing music. The great thing about the music skills are that you don't have to be able to sing or play. You can participate on whatever level that really suits you. Pharmacological management is used for severe levels of anxiety, and it can be treated by working with a mental health professional. At this stage, medication may be recommended along with those alternative or complementary therapies that I mentioned earlier. Pharmacological treatments for anxiety disorders have become more tolerable, available, and numerous, actually, over the past half century or so. And through the specific treatment plan, they will depend on the individual needs for benzodiazepines, as they are our gold standard. And they are depressant drugs, which means that they slow the messaging traveling from the brain to the body. However, they don't actually make people feel depressed. So there are three types of benzos: the short-acting, the intermediate, and the long-acting. And the short-acting, like lorazepam, they have a longer withdrawal effect, and they can be considered to be a bit, I think there's a question, but they can be considered to be a bit more addictive. So the shorter-acting lorazepam, as I said, does have a longer withdrawal effect, and it can be considered a bit more addictive. For severe persistent anxiety, consider the clonazepam regularly, and starting with 0.25 milligrams BID to 0.5 milligrams BID. For severe chronic anxiety, we may also consider the selective serotonin reuptake inhibitors, paroxetine, or you may know it as Paxil, venlafaxine, which is Effexor. It's actually an SNRI. It does increase the serotonin, but it also increases the norepinephrine levels as well. Nefazolone, which is a new antidepressant that is a structural analog of trazodone, but it's less sedating. Actually, this isn't a new antidepressant. It's back on the market. So it was on the market many years ago, and in 2021, it came back to us. So its structure is distinct from the SSRIs, the tricyclics, and the monoamine oxidase inhibitors. It achieves the clinical effect by inhibiting the reuptake of primary serotonin, but also norepinephrine. And then finally, we have the buspirone, which is an anxiolytic, not an SSRI at all, nor an SNRI. It does its action through the increases the action of the serotonin receptors in the brain, and it also binds to the dopamine receptors as well. So it doesn't actually work the same as an SSRI. However, now that our minds are boggled with pharmacology, let's put all of this into action as we meet Mr. Jim.
Thank you, Nancy. That was incredible. So we're going to start with our case study, Mr. Jim. I'd like to introduce you to him. He's a 69-year-old retired stockbroker, and he's had a recent diagnosis of inoperable carcinoma of the lung. He lives alone. His wife died 5 years ago of pancreatic cancer. And following her death, he has had episodes of anxiety and heart palpitations. His family doc has noted that in the weeks following his diagnosis, Mr. Jim has developed marked anxiety and has complained of shooting pains in the anterior chest, his head and neck, which are migratory and inconsistent. The chest pains are different from the constant left-sided chest pain that he originally had on the diagnosis of his cancer. And it seems to come at bedtime when he's trying to fall asleep. So I'll ask you to start using our algorithms and our assessments. And when we think about Jim, what are you thinking about? What do you think about his chest pain? Do you think it's cardiac related, or is it related to his cancer? What makes you think that it's not? And is it a red flag that he has had this recent diagnosis? And if you think about the things that people are most afraid of, it's cancer, right? It's the number one fear that people have. Jim lives alone. So that puts him at risk for anxiety and depression as well. And the biggest red flag for me is his wife recently dying. And I think we underestimate the impact that this has on patients and families, because as with anxiety and depression and other psychological illnesses, we tend to not treat grief and bereavement the same as we do with physical disease. And so for me, I would want to explore, what was his wife's death like? Was it a good death? Who was present? Were they well supported? Did he have support afterwards? Did his family have support afterwards? Did they do all of the things that they needed to do to honor his wife? And as far as the chest pain and palpitations go, I would hope that we would do a fulsome cardiac workup just to rule that out, even though he doesn't typically describe what we know cardiac disease is normally described as. But once we rule that out, then we can easily move forward and try and support Mr. Jim using our ESAS and our algorithm. So, and I've got it right in front of me, the Cancer Care Ontario algorithm, but I can't seem to say it today. So using our algorithms, where would you put Mr. Jim? And you can just put in your chats where you think he is. What do you think's happening to him from a CNS perspective? What chemoreceptors are being transmitted? And I think it's really important that we do a very fulsome head to toe assessment and med assessment. Remember, we talked about at the beginning, looking to make sure there's nothing else that's contributing to these symptoms. And asking if he has seen a professional about anxiety in the past, and would he be willing to do that? And I think, clarifying some of these symptoms. Do you feel at any time that you would not be able to stop or control these anxiety feelings and worries? Are you easily annoyed and irritable? And are you seeing any triggers that are escalating or creating these feelings that you're having? So where did you score, Mr. Jim? I think by our ESAS, we score him between the mild 1 to 3 and moderate 4 to 6, right? I think we need to dig in a little deeper and find out exactly what's happening. Mr. Jim has reported to his visiting nurse that he occasionally awakes with a sensation of choking, sweating, and shaking, which lasts a few minutes and accompanied by tingling in his fingers. What a terrible way to wake up. I think we really need to help this gentleman, right? Exactly, exploring that, teasing out between the mild and the moderate, and using things like, help me understand the reasons you would not like to talk about this. And initializing this discussion by telling people, we're just talking right now. I'm not expecting you to make any decisions. And this is a safe place to talk about these things. And tell me what worries you the most. You might be surprised. It might not be about their own physical end of life. It may be all of the rest of the things, how they're leaving the family. Are they going to be able to look after themselves? All of those sorts of things. And I wish that things were going better for us so we didn't need to talk about this. Just acknowledging that this is really difficult. So our case study continues. Mr. Jim, a little bit more about him, is normally an outgoing person, but he has never found it easily to express his feelings. And I know a lot of men just like that. I don't mean to be sexist, but he has led a very productive life and expresses pride in his work and his children. He has always needed to be in control of his environment, and this illness has led to conflicts with his daughters over lack of medication compliance. And he has been prescribed morphine, naproxen, and laxatives due to the chest wall involvement. The girls are feeling adamant that a prognosis should not be discussed with Mr. Jim for fear that it will make his anxiety worse. And I noticed that somebody in the chat put the I wish, I worry, I wonder. And I love using that acronym, and it helps people give them time to actually talk about what's going on. I think I would acknowledge his strengths, and I would say, Jim, I can see that you are a very strong person and your strength is important in your family. But I think there's a lot that we can do to help prepare your family for what is going to happen. And encourage family discussions and say something like, I feel it would be good for all of us to continue discussing the things that we have just talked about. And we brought up these very difficult issues early, giving you enough time to think about what is important to you so we can honor you and follow what is best for you. And we want to give people time to digest and think about what they've just been told, right? We may only be able to acknowledge 2 points in one visit, and giving people control, right? That's right, giving people control back. So Jim has always been a very active person, despite his advanced disease. And only weeks ago, he was able to play golf a few holes with his friends, but now he's very limited by dyspnea. So I think that's a red flag for me that I want to go back and look at him from a physical perspective, doing that assessment on his medications and how does his chest sound? Is there anything that we can do to support that dyspnea symptom? Or is it all related to anxiety? And he does well if he's very busy, but he reportedly says that he is having trouble concentrating and even has difficulty reading the newspaper. So what do you think? Do we need to intervene? Do we need to treat? I think we need to use the validated tool, the Cancer Care Ontario algorithm, to see, is there treatment required here? So his physician decides to order Ativan, 1 milligram PO at bedtime. And she is concerned about his need to maintain control, poor medication compliance, and conflict with the family may make the last days distressing, and ask the visiting nurse to continue doing her ESAS scoring tool on a weekly basis. And I just want to remind you that no one needs to order that test, that validated assessment tool. You can use that at any time, and using it frequently, we'll see where people are. Have they gotten worse or better? Have their symptoms improved or have they gotten worse? Expressing and recognizing empathy. I am sorry that you are feeling so anxious, and this must be very scary for you. Getting permission to talk about this and support them, and asking if we can talk about this a bit more so that we can make him feel better and provide some support. As we move on, Mr. Jim's next appointment, he looks worried and says, I don't know what will happen to me, but I'm going to keep going for as long as I can. He doesn't mention his diagnosis and changes the subject when asked about his thoughts on his illness. On other times, he talks about getting his affairs in order. He also reports continued insomnia, frequent wakefulness in the night, and he cannot concentrate on any task and is getting frustrated by his inability to follow a book or a movie. The episodes of dyspnea seem to be getting more frequent. And with further questioning, what would be helpful in determining, has he escalated from mild to moderate, or are we heading into the severe anxiety area? I think I would start with, I can see that you are a person who feels strongly, and I have a lot of respect for your strength in staying with this very difficult conversation. Again, yes, somebody's put review goals of care and find out more about his wishes. And just, saying, I have some difficult questions to ask you. Sometimes when people have mood changes, they have thoughts about harming themselves or ending their lives. Is there a chance that you would end your life or cause harm to yourself? And if the answer is yes, we know that he's under that severe anxiety phase and that we need intervention, whether that means a visit to the emergency department, crisis intervention, or a mental health specialist that has the capacity to order medications and support and keep Jim safe. When you meet again, Mr. Jim now reports that he's feeling anxious about his symptom progression and his dependence on his family. Mr. Jim continues to refuse discussion related to any advanced care planning. What symptoms now indicate that his anxiety is still present? He's reflecting on his history and talking about the symptoms that he is feeling, right? And he still, it sounds like he is not wanting to talk about the future at all. I know that these are very difficult issues to talk about, but because you care so deeply for your family, by involving them will help them prepare and cope. I wish things would slow down, but I worry that you won't be prepared if things don't go as we planned. And just making sure that we are following those goals of care and giving opportunity for patients to express what's happening. With continued use of the Cancer Care Ontario algorithm and other validated tools, Jim's nurse and physician recognize the presence of moderate anxiety. Acknowledging the fear of the unknown exacerbates Mr. Jim's anxiety. And it was treated with a benzodiazepine, and we started an antidepressant specific to alleviating panic, as well as some psychological support and counseling. Mr. Jim required clear information at every stage of his illness, as this gave him control, right? He was encouraged to share his concerns with his family and medical staff. He is now aware that he can benefit from a clear plan of ongoing care and the steps that he can take to maintain his own health and independence, like his personal responsibility to managing his pain. Mr. Jim has a strong internal locus of control, and he will require more time for discussion and investigations and treatments. So making sure that we plan for that little longer conversation, and treatment and physical limitations, the psychological and spiritual issues. We didn't really talk much about that, but that's really important that we check and make sure that if people have spiritual needs, that we reach out to clergy or anybody that they wish to speak to about their spiritual health. So using those domains of care and being really carefully listening using validated tools. Thank you so much. I hope that you have found this useful. Nancy, your non-pharmacological interventions, just excellent. I know that you practice those often with your patients. And if you have any questions, we'll open up the floor to that. You all got 100% on the test.
Hi, Danielle.
For the presentation. You've addressed my following questions sort of through your examples, but I wondered if you might offer either reiteration or ideas around when you talk to someone and they verbally say, everything's fine, we're good, and you sense that's not true, either because of the nonverbal or other comments from family members or from previous observations, how you may broach this topic just to see if there's an openness to discuss and not just sort of move on because they said they were fine.
Mm-hmm. I think when we use that I wonder, I worry acronym as well, it gives people an opportunity to talk about things in a very safe way. And it also allows the patient to understand that we really care about what's happening to them and that we're there to help them and respect them and all of the things that they've been through, really validating the feelings that they're having and understanding that these things are very difficult to talk about, particularly if people have had trauma, and using that trauma focus of care, making sure that we understand what this person has gone through, what they've endured. Maybe his wife's death was not a good one. And so that would escalate his anxiety so much, right? Because his experience wasn't good. Or on the other side of that, maybe they had an excellent experience. And so their anxiety level might be less because of that.
For sure. And I'm just wondering about that junction between a time where someone states things are fine and then the response, so that it may not seem like I'm disregarding what they've said or don't believe them. They don't feel necessarily as challenged if there's like that connection point to start that exploration to lead to the I wish, worry, wonder. I don't know if you have any thoughts on that.
Nancy, do
No,
you have any?
Danielle, I actually do, Danielle. I may ask your patient what his impression is of the symptoms that he has. So even though he's telling you that he's fine, I think sometimes if we are 100% honest and open with our patients, and first of all, allow them to tell us what their perception is, and then follow that with what our perception is, and that we are part of the public. So this is how I see you as your doctor, as your nurse, as your healthcare provider. And I also want to share with you as my patient, because I care so deeply about the outcome. I'd like to be able to share with you, if you're open, as to how your family and your friends are seeing you as well and what their concerns are. And asking your patient when is a good follow-up time for them, because that's difficult for us, isn't it, Danielle? To actually try to put a schedule onto our patient when maybe if we just say, when can I follow up with you? And if it's unreasonable, I would mark that by saying, I was more thinking.
Right. Wonderful. Thank you both so much.
You're welcome.
And we do have a question in the chat here. I'm not sure if you can see the chat or not, but I'll read you. Laura has asked, would your approach be different if someone had a history of anxiety or a diagnosis of generalized anxiety disorder, etc.?
Well, I think that we've identified that that's one of the red flags that would encourage you to use this strategy and these validated tools more quickly or earlier on your assessment, because they have higher risk to have anxiety that may require treatment. So definitely it would be something that it would be a red flag for me. So I would be having that in the back of my mind and exploring what that experience was like for them, what caused them to seek help, and how they responded to the treatment that they received, and being respectful of the choices that they've made, dealing with whatever it was that they were dealing with, right? And especially for people that have family history as well, knowing that they're at higher risk.
Wonderful. Thank you so much. And there's another one here. Our elderly often don't get the help that they need, as it's not always holistic care. How do we get them to focus on the mental health of our elderly, especially when they are presented in the ER?
Amanda, can you repeat part of that? It was a little bit fractured for me.
Sure thing. Our elderly often don't get the help they need, as it is not always holistic care. How do we get them to focus on the mental health of our elderly, especially when they present in the ER?
Oh my goodness. So that's a really great question, actually. And I think when we have patients come into the emergency department, particularly now, they often tend to be on their own rather than having a family member that's actually able to be with them. Being able to share an electronic medical record is huge, number one, to see what have the past experiences been with this patient, and finding out, having the point of contact right away to know what the patient has used prior to. When we talk about holistic care, it has often been that this holistic care coming forward really is more our generation, isn't it, than the generation before us. I say that kind of tongue in cheek because it's such an old, ancient history, but we are encouraged more today. We're melding more with Eastern and Western medicine. So first of all, I would have a bit of a docket with my elder to make sure that when they go into the emergency department, they know who it needs to be contacted, number one. They know what the patient has been through. It's like a little bit of a passport, right? I don't know if I'm actually answering your question directly. I don't know if you're looking for medical intervention or if you're looking more to help with the psychosocial piece of getting the care that the patient needs. But I'm hoping that I'm meeting you there part way. Can you tell me if I'm on the right track?
I'm not quite sure. I think the individual who's asked the question has actually
No,
had
sorry,
to
I'm here.
leave. Oh, there you go.
Sorry. No, I
Okay.
just find that a lot of my clients, when they go in, they get checked for the bump or the bruise or something else, and then they're not getting, the underlying where the anxiety and what's caused them to present there, and they're getting sometimes medicated and sent home, but then within a day they're presenting to me with that same anxiety, and none of it's not getting addressed. So I didn't know, but sending like a passport, trying to send that in, maybe with the client, maybe that would help for sure.
And I think that Emerge is always a very challenging place to deal with chronic and all of that goes on with it, right? They're very focused on what the person has presented with. But if we can be that catalyst to help ask a couple quick questions from the ESAS, use that algorithm really quickly when we're doing our assessment, and then a good note off to, family doc or nurse practitioner or the long-term care home where that person came from, with a little bit of your concerns if you're the Emerge nurse, or even, encouraging consultation to different services, I think would be great. But I mean, Emerge is really a challenging place for people with complex illness, right?
Yeah, and I'm finding sometimes they're getting failure to thrive, but then the family are getting the call that they're coming back home. And then they're calling us saying, now what? So sometimes we've had to say, you can't take them back if you can't manage them because they're right back in there. So it's just trying to get that seen beforehand. But yeah, I think preparing the family or the patient before they go in, that passport's a great idea. Thank you.
Anna Marie?
Hi, thank you so much for this, for these workshops. I'm going to look at the other ones. Interestingly, I have an interesting case here just presently with one of my patients. And, I think it's one of the care things that we're putting in the care plan. And if we can carry with it, like you're saying, a passport, that the patient does not want to stay in hospital, does not want to be placed. I mean, my patient actually asked for MAID, went back home, and then decided not to have MAID. He's 95 years old and he's able to make those decisions. However, I think if we all speak the same language within the multidisciplinary team, if possible, that's to say, you're going to go to hospital, you need to go to hospital, but you're coming back home. We need to have you go to hospital for an assessment, but you're coming back. And I think sometimes that helps out too for our elders, knowing that they're being respected in whatever decisions have been made prior to going to the ER for XYZ reasons. Thank you again for everyone that's on the panel.
I think that's it for the questions in the chat box. If no one else has any questions, I'd like to thank you both very much for your wonderful presentation today, and to everyone for taking the time out to be with us. A copy of the recording from today's presentation, along with the tools, will be sent out at a later date, a couple of days' time. Thank you all so much. Have yourselves a great day.
Thank you.